We have three great talks here. The first one will be by Dr. Richard Fogel from St. Vincent Medical Group in Indianapolis, and he'll be discussing the role of cardiac imaging in the management of heart rhythm disorders. Thank you.
Thanks. So I'd really like to thank the people that developed the program for inviting me, because this has been a wonderful symposium. And I'd really like to thank everybody who's staying for the last hour of the program. I have a little bit of a daunting challenge, because the title of my talk is The Role of Imaging in the Management of Cardiac Arrhythmias. And when I was assigned this, I was thinking, what the heck am I going to talk about? I mean, what modality? Echo, nuclear, cath, MRI. What aspect of it? Are we going to talk about how we use it for ablation? Are we going to talk about how we use it for diagnosis? Or are we going to talk about how we use it for whatever? So, by the way, there are my disclosures. In the past, before 2011, I did some speaking on behalf of certain medical companies since 2011. The only possible conflict is I'm a part owner of a local cardiac hospital. So, as I was saying, how could I conceptualize this, and how could I make this useful and practical for you all? So I've kind of divided this into two halves. The first half is really geared for those of you who don't hang out in the EP lab, and it's really how we use imaging in the EP lab, how we use fluoroscopy and ultrasound and these other things in the EP lab. And we talked a little bit about that earlier. Dr. Lack already kind of talked about that. And then the second half, we'll really be talking about the role of imaging in risk stratification for sudden cardiac death. So with that as an introduction, the role of imaging during procedures. So as Dr. Lack already said, there are many toys that we have. But if you go back to it, the most common method we use is fluoroscopy, fluoro. It's what we're all trained on. It's easy. You step on the pedal, you see the X-ray image. It has high temporal resolution. You could set the frame rate, but it's got some significant disadvantages. Not only does it have the radiation exposure that we heard about, and not only do the operators have the orthopedic problems because they're using lead, but fundamentally, fluoroscopy, just like anything in X-ray, is a two-dimensional representation of a three-dimensional process. And it also doesn't visualize soft tissue. Now, I've been in the EP field. I passed my boards 20 years ago, so I'm coming up on recertification. But the first non-fluoroscopy imaging modality that came in for procedures was really intracardiac echocardiography. So basically, the way this came about was we started doing ablations on the left side of the heart, in the left atrium, or the left ventricle, or for accessory pathways. Because if you remember, 20 years ago, the only really ablations we did were AV node reentry and accessory pathway Wolff-Parkinson White ablations. And sometimes we wanted to go through the septum, transseptal, to get to the left atrium so that we could ablate left-sided accessory pathways, because most accessory pathways are on the left side. And you could either go across the aortic valve retrograde, or the other way was to go transseptal. The trouble is, 20 years ago, EP didn't know how to go transseptal. We'd always have to call a cath guy in, usually an older cath guy who had done transseptal caths. And then as we started doing more and more, and we started accessing the left side more, industry, necessity is the mother of invention. They said, well, we're going to help you, doctors. And they developed this intracardiac echocardiography catheter, which was an echo probe on the end of a catheter, so with which you could see the intra-arterial septum. So then transseptal catheterization became really easy, because you could actually see where you were going in 3 dimensions. So the first non-fluoroscopic imaging modality was echo, and it allowed the real-time visualization of catheter and cardiac tissue, and it was radiation-free. I've never seen a study saying that radiation does a lot of damage as long as it's not excessive high-frequency radiation. Disadvantages, well, you all know that there's this thing called healthcare reform. We have to be very cost-conscious. So there's cost. It's a large catheter, large vascular access required. Echo still gives you mostly a two-dimensional representation, although there are some things that you can do by turning the ICE probe, the intracardiac echo probe, to give you kind of a three-dimensional feel. The next big thing that happened was, as we got into more complicated ablations, these 3D electroanatomic mapping systems. And if you haven't seen them, they're really like a GPS system. An electric field or a magnetic field is created around the body, and then the catheter the system is able to sense exactly in three-dimensional space where the catheter is. and it's able to project that up onto a map. And using that mapping system, you can create a shell of where the cardiac tissue is, and then you can measure certain things about that shell. You can see the electrical activation timing of that shell or that point that you specifically pick, and you can see the electrical voltage associated with that point in the shell. So this actually was the first thing that kind of gives you this three-dimensional representation, and you could manipulate it because it was all 3D generated. It was all computer generated. You could manipulate the image, so you could create this shell of the heart or of the chamber of interest. Then you could rotate it. You could look at it from the side. You could look at it, and you could do it all just using the computer. It has become the mainstay for most complex ablation procedures, including AFib procedures and almost all VT procedures. Not all VT procedures, but most VT procedures. The advantage is it's a marked reduction in radiation. It doesn't require radiation. It actually allows you to have this three-dimensional representation, and it gives you the ability to mark and return to different cardiac locations. So you put a catheter in a certain space, the system knows where that space is, you move the catheter away, and then you go, oh, that was a good space, and you can put it exactly back there. And when you do that fluoroscopically, remember, that's a two-dimensional representation. So if you want to say, I'm going to put it here, you don't know what the depth is of where you're putting it. The disadvantage, it's costly, and it takes a little bit of additional time. Usually that little additional time, in my mind, is offset by the reduction in X-ray imaging. Here's an example, and I'll point, more of the audience is this side, so I'll point over here. And you can see that this is a view. This is actually of atrial flutter, and you can see that this is a timing sequence activation, and you can see that you have early activation, and then you can see that the circuit kind of rotates around the tricuspid annulus, and you can see that you have early activation meeting late activation, and early activation meeting late activation is the hallmark of macro reentry. So this technique, electron atomic mapping, I think really revolutionized how we approach arrhythmias in the electrophysiology laboratory. Some other techniques that are used, computed tomography, CT scans, another 3D visualization of cardiac structures, very helpful in finding things like pulmonary vein isolation. Advantages, very high spatial resolution, relatively fast, and everyone has a CT scanner. Disadvantages, more radiation. The images are not usually obtained at the time of the procedure because the CT scanner usually is separate from the EP lab. There are some research places where they combine CT and the EP lab, not very common. And what the technique then is to take the CT image, and you can either see what you want to see and then kind of remember it in your head, or some of the more advanced electron atomic mapping systems allow you to integrate or register the CT image with the electron atomic image, so you've got really, really good definition of structure from the CT scan, and then you can combine that with the electrical activity that you get from the electron atomic system, and you can create some very powerful tools for mapping cardiac arrhythmias. And that's what I listed as the new technologies. You can do a similar thing with magnetic resonance imaging. Again, the advantage of MRI is very high quality anatomic information, ability to obtain some functional information about metabolism and scar and things like that. And again, you can integrate that and register that with electron atomic systems. The disadvantage, not real time, expensive, and as you heard from Dr. Esservathan, not supposed to do MRIs that much in people with ICDs and pacemakers. Not saying you can't, but also if you're doing a cardiac MRI in someone with an ICD, there's the issue of artifact from the MRI lead. And then there are some very fancy new research systems. They call them these XMR systems. I frankly haven't seen one. I've just read about them, where they actually bring an MR and they put the MR machine in the fluoro room. So you kind of combine real-time MRI with EP. I think that's just the stuff of research and dreams. But who knows? Maybe one of the faculty has one of those systems. So that's really the first half. And so kind of giving you an overview of how we use imaging to facilitate what we do in the EP lab. The second half, I'd just like to talk about the role of imaging in risk stratification. So risk stratification really refers to how do we select who is at risk for sudden cardiac death. And traditionally, the technique we use is we use EF, ejection fraction. The lower the EF, the lower the ejection fraction, the weaker the heart, the higher the risk of arrhythmias. That's a pretty crude technique. With all our sophistication, maybe we should be able to do better. So, as you know, different modalities give you different EFs on the same patient. So you get an echo and it says 25%. You get a cath, it says 20%. You get a nuke, it says 38%. And then what do you do? And so my philosophy is I take the one that lets me do what I want to do with the patient. I think that's what we all do. I mean, if you want to put a defibrillator in, you use the low one. If you don't, you use the high one. And again, I think that EF is very, very crude. And it also creates what I call the paradox of, well, not what I call, but what Dr. Meyerberg has called the paradox of risk stratification. And it kind of looks like this. The paradox is the absolute highest number of sudden cardiac death events occur in patients without left ventricular dysfunction. There's a typo there. So if you look at, and again, I'll point on the right here, if you look at the universe of people who have sudden cardiac death in the United States, around 300 to 400,000, but it's a very small percentage of the total population. As you can't read it so well, but as you start layering different things on, like coronary artery disease, like reduced ejection fraction, it is true you can select out people who have a significantly higher risk of sudden death. But as you do, you start diminishing this total population. So you might be able to select out the 50 or 60,000 people who are at really high risk because they've got an ejection fraction less than 35%, and they've got non-sustained ventricular tachycardia, and they've had an old MI. But the problem is that you've selected out a high-risk group, but you've missed the vast majority. And that's an important concept because you've potentially saved a lot of people, but you've missed the vast majority of people who you really want to save. And how do you put a dent in sudden cardiac arrest if you can't really identify who these people are? So in the remaining 5 minutes, I'm going to talk a little bit about the use of MRI to help in risk stratification. And I've been very fortunate because we've had some very good MRI cardiologists, which is a burgeoning new field at my institution. So I have to confess, I fully don't understand how MRI works. I know there's a magnetic gradient field that's put over it. I know they disturb the atoms, and then as they return, they release a signal, and somehow this computer and these detectors can integrate that into an image, and then they call it a T1 image or a T2 image, and they talk about these sequences. But regardless, it is a technique where a magnetic field is applied that they can use to create very high density, high fidelity, high image integrity maps of structures, including the heart. The contrast agent is this substance called gadolinium. And gadolinium is contrast for MRI, just like IV dye is the contrast for CT scan. And the key thing with gadolinium is it doesn't cross the cell membrane. So in normal myocardium, in normal heart tissue, the tissue is mostly intracellular. Therefore, after you give gadolinium, there's not a lot of extracellular space, and there's very little pickup of the gadolinium. In the presence of scar, dead tissue, the extracellular space increases, and therefore, after you give gadolinium, after a few minutes, you have what they call delayed enhancement. The tissue with a scar picks up the gadolinium. And it turns out there's a very high correlation between delayed enhancement and defined scar and electroanatomic defined scar. So if we put a catheter in and we see that there's no voltage coming from a particular area, that area is dead. And it turns out that there's a good correlation between areas that are not making electrical activity and areas that show high delayed enhancement. And that's shown really on this. And what you see is you see the MRI here, and you know, they've outlined where the scar is, and they've projected it into a three-dimensional representation from the MRI. And this is the electroanatomic map, and you can see a very good correlation between the MRI-defined scar and the electroanatomic-defined scar. Now, a really important point for arrhythmias is tissue that's alive and healthy is generally not arrhythmogenic. And tissue that is frankly completely dead, it's not arrhythmogenic either because it's dead. Dead tissue doesn't make arrhythmias. It's the tissue where you've got that borderline between healthy, sick, and dead tissue that kind of creates the substrate for reentry, where you can have areas of normal conduction next to areas of not normal conduction, next to areas of no conduction, where you can create the circuits for reentry, which causes most of the arrhythmias we think about, especially ventricular tachycardia and ventricular fibrillation. So earlier today, we also talked about hypertrophic cardiomyopathy, and we talked about genetics for risk stratification. But genetics for hypertrophic cardiomyopathy aren't that good because we're not sure we know all the genes, and then some of the genes are associated with moderately high incidence of sudden death. It's very confusing. So some people, including Dr. Marin and actually Dr. Marin's son, who's a cardiologist as well, have really looked at this and they said, does the degree of scarring as detected by MRI correlate, or detected by delayed gadolinium enhancement, correlate with arrhythmias? And that's exactly what they found. Delayed enhancement correlates with ventricular arrhythmias and is associated with risk of sudden death. Now, you never see a picture this good, but here's an MRI. It's in the short axis. This is the left ventricle. This is the right ventricle. Normal myocardium is nice and black. The cavity is blood here. And you can see that in the wall, you've got this very patchy scar. And when you have patchy scar with normal tissue or sick tissue next to dead tissue, that creates the substrate for reentry. So the more patchy scar you have, the higher your risk of arrhythmias. And I think that's pretty clear. So here's an example where EF may not be the best risk stratifier, but the amount of scar and the distribution of scar may be an effective risk stratifier. Same thing can be said for ischemic cardiomyopathy. So in ischemic cardiomyopathy, the scar is mostly endocardial or to transmural. And the amount of scar detected by delayed enhancement correlates with inducibility, that's been shown, and with prognosis. And the amount of infarcted tissue, heterogeneity, the amount of heterogeneity within the particular tissue of interest correlates with spontaneous arrhythmia and defibrillator shocks. And that was shown here, where this shows the increase in defibrillator shocks with the amount of different tissue heterogeneity. So we talked about hypertrophic cardiomyopathy. We talked about ischemic cardiomyopathy. You can do the same thing with non-ischemic cardiomyopathy. The hallmark of non-ischemic cardiomyopathy is mid-wall enhancement. And unfortunately, it doesn't project all that well here, but you could see, I'm trying to find areas, but it's hard to see in this projection, where if you came up close, where you see scar in the mid-wall. And there's clearly a correlation of scar and the location of the arrhythmogenic substrate for endocardial versus epicardial discrimination. And the predominance of scar distribution of about 26 to 75% of the wall thickness predicts inducibility with an odds ratio of 9 in one particular study by Dr. Nazarian from Johns Hopkins, who's done a lot of this work. Also, when we go to ablate VT, it's really nice to know if the substrate is endocardial or epicardial. And maybe Dr. Callens will talk a little bit about that later on in his presentation. So I've tried to stay on time. It says I've got 45 seconds left. So I'm staying on time today. There are multiple modalities, each with its own cost for imaging, advantages and disadvantages to assist the electrophysiologist during ablation. The challenge is using the right one at the right time. I think that's our call, especially in these times where we have to be very conscious of cost. Risk stratification is more complex than ejection fraction alone, and MRA delayed gadolinium enhancement may offer additional information for risk stratification. The amount and pattern of delayed enhancement is critical. 13 seconds. Thank you.